Hello, my name is Anastacia Tomson. I'm a medical doctor, a human rights defender, and an author, working predominantly in the field of rights for the marginalized and specifically the LGBTQIA+ community. And it's my pleasure today to introduce you to a subject titled HIV and Me. It's a challenge for someone in my position to tackle a topic that's as broad and expansive as this one, recognizing that we as healthcare professionals and future healthcare professionals are often all too easily bogged down in the scientific minutiae, pathology, virology, pharmacology, and physiology of medical conditions without paying adequate attention to the social issues that underpin them. I hope that today you'll gain something from this discussion, not just in terms of scientific fact and evidence, but also in terms of reframing your perspective and your attitudes towards HIV. Of course, if you need to reach out for assistance, I'll make myself available to do the best that I can to assist you, and I hope that you'll make use of the contact details that I've provided. A discussion like this needs to begin by examining what HIV is, and simply unpacking the acronym Human Immunodeficiency Virus is really not enough to understand this complex challenge that faces us in 2020 and going forward. In a very scientific sense of the word, HIV is an RNA virus composed of genetic material enclosed in a protein-coated capsule. It's also a retrovirus, and what this means is that the virus's genetic material is transcoded into DNA by an enzyme called reverse transcriptase. And the DNA that emerges from this process is then integrated into the genome of host cells. In short, the virus works by spreading itself throughout the body, depositing itself in reservoirs, and incorporating itself into the genetic material of the host or carrier of the infection, in this case, people. We need to consider the ways that HIV spreads, and we call this transmission. HIV is a blood-borne illness. It spreads via body fluids. Blood is the most prominent of these, but certainly it appears in other fluids to varying degrees. And as you can see, these include semen, preseminal fluids, rectal fluids, vaginal fluids, and breast milk. It's important to understand that the virus can only infect a host by coming into contact directly with mucous membrane or into the bloodstream. It cannot be spread by contact, handshake, hugs, or any other kind of interaction with an infected person. The primary mode of transmission of HIV is, of course, as many of us are already aware, through sexual intercourse. Sexual intercourse itself is a complicated concept and one that we don't often adequately unpack or interrogate. Some of the primary forms of sexual contact are listed for you here, namely penile vaginal, penile anal, penile oral, penile vulval, and of course oroanal. It's important to use the words that refer to the anatomy involved in sexual contact because, as we'll understand through the course of this discussion, sexual intercourse is not necessarily just between a cisgender straight man and a cisgender straight woman. It's also important to recognize in any conversation about HIV or indeed any other sexually transmitted infection that sexual intercourse can be consensual or non-consensual, and this is something that we'll unpack further still. Other modes of transmission that we need to consider as healthcare professionals for HIV are mother-to-child transmission that can occur either during the process of labor or birth or through breastfeeding after delivery. Sharing of needles, as might be common with people who inject drugs, is another mechanism through which HIV can spread, as is blood transfusion, though of course there are strict regulations and policies to try to ensure that any donated blood is adequately screened for pathogens before it's administered to a recipient. Understanding transmission isn't enough to recognize who is affected by HIV. And in order to have this discussion, we need to begin with the concept of risk. For someone who starts out HIV negative, unaffected, or uninfected, more accurately, by the virus, because we can argue that we are all affected by it, risk refers to the likelihood that someone will be exposed to and contract the virus, that that genetic material will be incorporated into that person's host genome. Risk is directly affected by the things that we do. It's a concept that is related to behavior, the way that we navigate through this world, the interactions that we have, the kind of sexual activity that we participate in. In fact, even our professions can contribute to the degree of risk that we carry. We spoke about HIV being present in various body fluids, and it is present in differing concentrations depending on the fluid in question. It's this concentration of virus in the fluid that confers the degree of risk associated with sexual activity. If we consider semen or pre-ejaculate, in addition to blood, we recognize that there's a high concentration of HIV in these fluids. There's a lot of virus floating around in semen. There's a lot of virus floating around in blood. These are the playgrounds of the HIV virus. If we look at vaginal secretions or breast milk, indeed the virus is present, but in lower concentrations. In other body fluids, specifically saliva, mucus, tears, sweat, urine, and of course feces, virus can be present, but often in negligible quantities. Understanding the concentration of virus in different kinds of body fluid, we can extrapolate and determine the risk associated with various kinds of sexual activity. The highest risk activity that we have in terms of HIV transmission is penetration of either the anus or the vagina by a penis, whereas other activities, such as oroanal sex or conventional oral sex, have a much lower risk. It's also important when we have this discussion to recognize that co-infection with any other kind of sexually transmitted infection will increase someone's risk of contracting HIV. And the reason for this is that all sexually transmitted infections result in inflammation, and that inflammation increases the permeability of the tissues to the virus. In other words, because of the inflammatory process going on and the immune response mounted by the body against sexually transmitted infection, the tissues in question are more easily penetrated by the virus. The virus can gain access to them and start replicating within the host. In order to paint a bigger picture of HIV and its effect on us as a society, it's useful to dig into the history, and I've prepared a small timeline which has a couple of highlights. Please note that this is not a comprehensive timeline of HIV. Such resources are available in far more detail on the internet, but I have pinpointed a couple of events that I think are noteworthy. HIV was first recognized in 1981, and the way that it was identified was that a very rare and unusual form of pneumonia started to ravage certain communities. This was recognized predominantly in the United States, in Los Angeles, also in New York City and the entire state of California. 270 gay men were identified with immune deficiency by the end of that year, with 121 deaths. The infection, when it was first identified, showed a predilection for this already marginalized community, and in fact, in 1982, the syndrome that we now know as AIDS, acquired immune deficiency syndrome, had a different moniker, GRID, gay-related immune deficiency, which shows that if we look at the history of this virus, it has had an intimate relationship spreading through marginalized communities, and that continues to this day. In 1986, mother-to-child transmission was first identified. You'll see as you glance further along the timeline that this was confirmed the following year in 1987. We also note that commercial testing for the HIV infection by means of ELISA, and we'll talk about the testing methods as we progress through the discussion, became available in 1985. By 1990, more than 300,000 cases of AIDS, please note not HIV infection, but acquired immune deficiency syndrome. This means people who have the viral infection but have gone on to develop unusual and often life-threatening opportunistic infections that have never been seen in otherwise healthy people with competent immune systems. So this figure exceeded 300,000 by 1990. We aren't able to pinpoint exactly how many people at this time were infected with HIV, but the estimates are already at 8 to 10 million across the globe. 1995 was the first time that highly active antiretroviral therapy, the principles and cornerstone of the treatment that we still use for this infection, became available. As you'll notice from the figures on the timeline, there were 4.7 million new infections reported by this point, 2.5 million of them affecting Southeast Asia and 1.9 million affecting sub-Saharan Africa. This was perhaps the first time that we had an inkling of just how significantly the burden of this emerging infection was carried by the global South. And of course, this trend continues to this day. It was 2002 when the South African Constitutional Court delivered a landmark ruling on the availability of nevirapine. It had been the struggle of an intense human rights movement fronted by the Treatment Action Campaign, which sought to provide access to this life-saving drug for millions of mothers infected with HIV in an effort to ensure that their children would not be infected either during delivery or after delivery. Something I didn't know when I was researching for this presentation was that the United States enacted a travel ban on anyone infected with HIV, either looking to settle in the United States or even to visit the United States. What this means is that if you were HIV positive and the authorities knew about it, you were entirely denied access to the United States unless you'd been able to secure a special exception or a permission. This travel ban was lifted by President Obama in 2009. 2012 marks the approval of PrEP, pre-exposure prophylaxis, something that we're still going to talk about during the course of this discussion, by the FDA in the United States. I speak about HIV as an equal opportunity infection, and I'm sure this will not be a surprise to you. You've heard many times, even before entering tertiary education and undertaking studies in the medical or allied health sciences, that HIV can affect anyone, regardless of orientation, regardless of race, regardless of gender, regardless of age. Having said all of this, we must still bear in mind that HIV is an infection that has a predilection for the marginalized. Although it can affect anyone, the burden of HIV is carried most significantly by people who are already marginalized in society. And what I've highlighted for you here are just a few examples of such people, specifically the LGBTQIA+ community. Intravenous drug users, or people who use drugs, people who inject drugs is the accepted nomenclature in this day and age. People with disabilities. It's also very important to understand that HIV affects women disproportionately to the way that it affects men. Studies have shown us that women are likely to acquire HIV 5 to 7 years earlier than men do. These are studies in East and Southern Africa, very relevant to us listening to this discussion in South Africa. We also know that globally, in terms of women aged 30 to 49 years, AIDS, acquired immune deficiency syndrome, the clinical endpoint of untreated HIV infection, is the leading cause of death. And that is a scary, scary statistic. Why are women disproportionately affected by HIV? There is no easy answer to this, and the extent of the social circumstances that surround these statistics that I've presented to you are unfortunately too broad for me to unpack completely in such a brief discussion, but I hope that the points we bring across here will serve as a starting point for reflection and consideration around why women carry this burden. We know that in society, even in 2020, women are marginalized. They do not have equal access. They do not have equal status, either in terms of cultural standing, social standing, or economic standing in society. And of course, these discrepancies are much more prevalent in the global south, but indeed they are prevalent throughout the entire world. There are legal factors that affect women's rights. They are not always empowered to make their own decisions about healthcare or about who they are married or wed to. They do not always have the freedom to pursue education and undertake careers. Often women are burdened with the responsibility of raising and caring for an entire household. We know that women are disproportionately affected by intimate partner violence. We know that women are affected by poverty, and we also have a building body of scientific evidence to show that in countries affected by natural disaster or by armed conflict, women are victimized, marginalized, assaulted, and generally discriminated against to a greater degree than they would otherwise be. These are all factors that contribute to the spread of HIV, particularly amongst women. When you do not have agency or independence over your body, your sexual interactions, your navigation through the world and through society, your chances of being infected, either willfully or non-consensually, are magnified. There are other social factors that need to be considered in understanding the spread of HIV and where the true burden of this infection lies. Despite knowing about the illness since the 1980s, and despite all of the advances in diagnosis, testing, management, programming, resources, and education, HIV remains the subject of so much stigma in society. It's not something that we are able to talk about freely. The burden of a diagnosis with HIV is still felt very heavily by the person who receives it. This stigma serves as a barrier. It stops people from gaining access to healthcare services. It discourages people from disclosing their status to partners. It can even prevent people from accessing testing and knowing their status themselves. We know in this day and age that one of the most effective ways to prevent the spread of HIV is through barrier methods of protection, and I speak specifically here about condoms. But in order to be able to use a condom, you need to have a condom. And while there are certain public facilities that make condoms freely available, there are some instances where people will need to purchase condoms. We also know that vaginal condoms are far more costly than penile condoms, which can serve as a barrier. It's not just about having the condom, though, because in order to be protected against HIV, you need to use the condom. And of course, there's a negotiation that goes along with that. It's not as simple as just asking your partner to apply a condom or applying one yourself, because in many situations, this is met with questioning or interrogation, intimidation, physical violence perhaps. Don't you trust me? Do you think that I'm dirty? Do you think that you need to use a condom in this space? There's a power dynamic that is at play here, and making the condoms available to people does not address this complex interaction that people still need to negotiate. There's a concept that you may be aware of, which I've highlighted here, called bug chasers. And this refers to people who are knowingly having unprotected sex or risky interactions, recognizing that they might contract HIV, and perhaps even wanting to contract HIV, because sometimes the reality of knowing that you have the infection is easier to deal with than the fear and the uncertainty of possibly carrying it. This is a complex process to understand and a difficult one, but in order to make sense of it, we need to recognize all of the barriers that people face in accessing healthcare, prevention, treatment for HIV, and of course the stigma that we've discussed around the infection. This is an illness that has ravaged marginalized communities throughout the globe, communities who are very well familiar with being on the wrong end of power dynamics. When we speak about marginalized groups, specifically people in the LGBTQIA+ community, or people who inject drugs, or people with disabilities, or people living in war zones, subject to armed conflict, or navigating natural disasters. These are people who already suffer at the hands of society. They don't enjoy the same kind of privilege that the rest of society has. I've already discussed the role of stigma, but we really need to focus on the impact that stigma has and the role that it plays in affecting communities who are already marginalized, who already find themselves on the fringes of society, seen as different, seen as abnormal, othered because of who they are. The populations that I'm talking about, and we will discuss them in greater detail, are the ones who don't have access to healthcare, who aren't able to negotiate condom use, who aren't necessarily able to test for HIV, and if they do test, aren't necessarily able to manage the result that they get, whether it's a negative result and the attempt to stay negative, or whether it's a positive result and the need to go on to treatment that is potentially lifelong. This brings us to a discussion around adherence. We are fortunate to live in a time where we have a multitude of antiviral agents that are very well capable of suppressing HIV infection and allowing those who are affected or infected to go on to live otherwise healthy lives of durations that are comparable to people who have never been infected by the virus. The problem with the medication is that it only works if someone takes it. In order to use the medication, you need to have the medication. You need to have access to a clinic or a pharmacy and perhaps a prescription, healthcare providers who will write that prescription for you. You need to be able to take that medication on a regular basis. You need to have a safe place to store it. You need to navigate the side effects of the treatment, and certainly in 2020, the medications that we commonly use have far fewer side effects than they used to back in the 1990s or in the early 2000s. But every medication has side effects, and we don't always adequately explain these to people before issuing that prescription. We also live in a day and age where some antiretroviral medications are sold on the black market as drugs of abuse, a particular culprit of this being efavirenz. I'm going to speak for a minute on the diagnosis of HIV infection, because if we don't recognize it, we're unable to manage it. HIV testing is always through the form of a blood sample, and we have various ways of looking for the virus either directly or indirectly. The oldest tests that have been available for the longest time, and I alluded to this on the timeline a couple of slides back, are antibody tests, specifically the ELISA or the Western blot. In this case, we don't look for the virus itself, but we look for the response of the host immune system. Antibodies, molecules that are directed against the virus and designed to bind to it. We are also able to test for proteins that are expressed by the virus itself. This is called an antigen test, and the most commonly used one is the P24 antigen, a protein that appears on the envelope of the HIV virus particle. In addition to that, we're able to look for the actual genetic code of the virus, the RNA that we spoke about right at the beginning of our discussion, and we amplify this through a technique called a polymerase chain reaction, or PCR. What's important to understand about these tests is that they can be conducted in a variety of different settings. We have access to rapid testing or point-of-care testing. This is a finger prick test that you might do with a clinic sister. There is formal laboratory testing, which is often used to confirm a diagnosis and exclude either a false positive or a false negative result. We're also living in an age where the idea of at-home testing for HIV infection, similar to at-home pregnancy testing, is becoming available, with all of the ethical quandaries that it brings with it in terms of post-test counseling. Testing has limitations, and one of the most prominent ones that needs to be discussed is the concept of a window period. When I speak about a window period, I mean that in between contracting the virus through an encounter or a behavior or an exposure event to the time that we are able to accurately diagnose the viral infection through the methods of testing that we've discussed, there is a time delay. The time delay depends not just on the testing methodology that we use, but also varies in an unpredictable manner from individual to individual. With the antibody test that we've discussed, specifically the ELISA test, the window period is typically given as 3 weeks. With antigen tests, such as the P24, the window period may be as little as 11 days. And when we speak about amplifying the viral genetic material through PCR, we could potentially detect infection as early as 3 days after an exposure incident. As I've mentioned, these periods are variable, and so after someone is exposed to the virus, our standard practice is to take a baseline test, which doesn't tell us whether they've been infected by the exposure, but rather whether that person had HIV infection before the exposure, and then to confirm whether that person remains negative either at 1 month or 3 months, depending on the methodology used, and of course, under the provision that there's no further exposure during this period of time. Testing and the discussion around it is nowhere near as simple as understanding the kinds of tests that are used and the window period. Put yourself in the position for a minute to consider that you have been exposed to HIV, whether through sexual behavior or occupational exposure or through a blood transfusion, and consider what it would feel like to wait for an answer on whether you've been infected or not. This is a life-changing diagnosis that can affect your interactions with friends, with family, with your social circles, perhaps with your workplace, certainly with any partners that you currently have or may have in the future. We've spoken already about the stigma that HIV infection carries even in 2020. But this stigma manifests itself in different ways, and through having the discussion around the science of HIV, what the virus looks like, how it spreads, how we diagnose it, how we treat it, and how we prevent it, we can see how the effect of that stigma manifests. Having access to tests or having the technology to be able to test for HIV does not mean that everyone who's at risk will be able to take that test and to get their result and to know their status. The fears about being stigmatized or further marginalized in society are very real. People have concerns about what will happen with that result. Will it be disclosed without their consent? We know that we value as health professionals confidentiality, but we also know that we don't always pay it as much respect as we should. And for patients, the concern over having this result released to other people can be very, very alarming. We need to think about legal issues that affect the populations who are at risk for HIV infection. Although it's not illegal to have HIV or to test for HIV, some of the people who are exposed to HIV will be members of marginalized groups. We've spoken already about people who inject drugs, people who are members of the LGBTQIA+ community. If you live in a country, and this is often the case, especially in sub-Saharan Africa, where your very identity is criminalized, showing up at a clinic and asking for an HIV test, where the healthcare provider is going to take a history from you and ask you about the incidents or the behaviors that you've engaged in, might put you at risk for incarceration, court cases, sentencing, physical violence, abuse by the authorities. We know that because of discrimination and marginalization, women might be less likely to have access to testing than men do. But we also know that even when they have access to testing, men are less likely to actually test for HIV infection than women. We also know that people who are targets of domestic violence or intimate partner violence often will not have the freedom to go and do an HIV test or to take action on the results. This brings me to a concept called key populations. If you haven't encountered this term as yet, I'm certain that as you progress through your studies, you will. I define key populations as people who find themselves on the wrong end of societal power dynamics. It's a problematic concept for many people doing work in human rights because it means that people who are disadvantaged in so many ways in society and who need comprehensive and holistic support in so many spheres are often acknowledged by the systems and structures only because of the role that they play in the spread of HIV infection. When we look at this list of key populations, we can see that there's a diversity of groups here. We have entries that correlate with sexual behavior. We have entries that correlate with the kind of work that people do. We have matters related to identity, to gender, to age, to disability. The common thread between these different groups is not who they are, but rather who they are not. They are not seen by the rest of society as equal. They are othered, they are regarded as the abnormal, and it is for that reason that they do not enjoy the same degree of access or privilege that the rest of society has in moving through this world. Understanding that this is a diverse group of different identities and that each of them has different needs brings us to recognize that you cannot have a single targeted strategy to tackle the burden of HIV in key populations. Each of these groups has its own specific set of requirements and its own challenges in upholding their human rights. And unless we tackle this issue on a holistic and comprehensive level, recognizing that these people have voices that are not heard with the same respect and authority as the rest of society, and looking at the reasons for that, we'll never be able to adequately alleviate the burden of HIV on these populations. To give you an example, let's pull out transgender people from the list that I've provided. We know that trans people are at higher risk of HIV infection, but this is not a product of being transgender in society. This is a product of the way that society treats a transgender person. When you don't have respect for your identity and you don't have access to legal documents that reflect who you are, and you don't have access to gender-affirming care, be it medical or surgical, should you wish to have that kind of intervention, and you don't have access to education or an equal chance at employment, these constellation of factors put you in a position where you are more likely to be at risk for HIV. If you don't have access to education and you can't find employment in your chosen field, you might resort to sex work, or you might choose to engage in sex work, but certainly the sex work will put you at risk for infection because we know that sex workers are not always able to negotiate with their clients on condom use. We also know that trans people might find themselves in a position where they are injecting either hormone therapy or silicone fillers, perhaps sharing needles in this space, again, putting them at risk of infection. We know that showing up at a clinic in order to test for HIV requires presenting your ID document and your legal name, and the misgendering and the dead naming and the public identification that trans people will face in a situation like this might leave them at risk of physical violence being targeted by the rest of their community. This can act as a barrier to testing, to diagnosis, to treatment. The same can be said for any group under this listing. We know that prisoners do not enjoy equal rights and don't have free access to healthcare. We know that people who inject drugs are often stigmatized and marginalized by society. They're seen as subhuman in so many ways. Showing up at a clinic for someone who does inject drugs can be an exercise in shame and humiliation, and they might be denied access to these essential services even if they are willing to endure the humiliation that goes along with it. This brings us back to a concept that we highlighted earlier. HIV is capable of infecting anyone, but it does have a predilection to prey on those who are already Seeing these populations through the lens of HIV infection alone only serves to ignore and invisibilize so many of the societal injustices that these people face. It is not HIV that is the primary concern in terms of the spread of the illness. And what I mean by that is it's not the pathophysiology of the infection or the virology of it. It is the social injustice that these communities face, which leads them to be estranged from services, to not have the same degree of access that most people would have, to not be able to have gainful employment or access to education or roofs over their heads. This is what leads to the spread of the infection. And we cannot treat these injustices through the rollout of antiretrovirals. We need to address the inequalities themselves at the root and think about how we can dismantle these structures, or at least play a part in that process. This leads us to a discussion on prevention, how to not become infected with HIV. And again, I will put out a disclaimer to say that medical advice or instruction is not sufficient in curbing the tide. Everything that we speak about now has to be considered in the context of the system that we've already discussed, with all of its multiple cogs. The strategies for prevention that we often quote would be the 4 Ps: reducing the number of partners, having sex only with protection, non-penetrative sex, and the prompt treatment of other sexually transmitted infection. There are a few other concepts that I'll highlight for you under strategies for prevention, including post-exposure and pre-exposure prophylaxis, and treatment as prevention. When I speak about protection against HIV or using protection in a sexual encounter, I speak specifically about barrier methods. This is not the same as contraception or birth control. It's important to know that birth control, through whatever form, the combined oral contraceptive, the injectable, coils, loops, Mirenas, none of these protect from any sexually transmitted infection, least of all HIV. A barrier method refers only and specifically to a condom. And I speak here about a penile condom, which people still mistakenly refer to as a male condom, or a vaginal condom, which might mistakenly be referred to as a female condom, paying respect to the idea that not all penises belong to people who are male, and not all vaginas belong to people who are female, recognizing that we've pointed out, for example, transgender people as carrying an especially high burden of HIV, and recognizing that until we tackle the needs of the marginalized in a holistic way, paying respect to their identities, we don't adequately fight the infection and we don't adequately protect human rights. When I speak about non-penetrative sex, these are all behaviors that don't involve the insertion of a penis into a vagina or into an anus. The list is limited only by your imagination, but I've given you a few pointers that I hope you'll find helpful, such as masturbation or mutual masturbation, thigh sex, breast sex, the use of hands or mouths. Sex is not always about inserting a penis into an orifice, and this reductive approach to sexual behavior only serves to strengthen the growth of HIV infection. To give a word on post-exposure prophylaxis, what I speak about here is pharmacological therapy that we give to someone who's had an incident that exposes them to HIV. We can only use this in someone that we know to be negative, so it does require a baseline negative test from the person who's been exposed. We provide antiretroviral therapy, a combination of 3 different agents, and if you care for the specifics, this refers to 2 nucleoside reverse transcriptase inhibitors combined either with a protease inhibitor or an integrase inhibitor. And these medications need to be used for at least a month after exposure. The other form of prophylaxis that is gaining traction steadily, and remember from the timeline, this was approved by the FDA in the United States in 2012, but is still not as readily available throughout the world as it should be, is PrEP, or pre-exposure prophylaxis. This refers to someone who's uninfected with HIV, who takes antiretrovirals either regularly or as an on-demand intervention for sexual encounters. The combination that we use here is usually two agents, tenofovir and emcitabine, used either as a daily dose taken every day or otherwise on demand, and I'll highlight for you the 2-1-1 strategy for PrEP. 2 tablets taken between 2 and 24 hours between sexual contact, a further dose taken 24 hours after the first, and a second dose taken 24 hours later. This period can be extended to incorporate any number of sexual encounters, with the important factors being 2 tablets before the first exposure and at least 1 tablet every 24 hours after the last exposure for 2 doses. Other techniques for prevention that we need to consider are the prevention of mother-to-child transmission of HIV, medical male circumcision, and harm reduction programs like needle exchange. We've spoken about people who inject drugs being at risk for HIV infection because of sharing needles. We know that if you give them clean needles, yes, they will still inject drugs, but they won't have the same risk for infection. This is called a harm reduction approach. The last concept that I want to highlight under prevention is the idea that U equals U, or treatment as prevention. And the acronym means undetectable equals untransmittable. We have very robust scientific evidence in this day and age to tell us that if someone's viral load, someone who's infected with HIV and who's on treatment, has an undetectable viral load in their blood, they will not be able to pass that infection on to anybody else. This means that adherence to HIV treatment for those who are already infected is one of the most effective forms of prevention. So now we come to the closing moments of our discussion, and this is really where the introspection and the reflection become so important for us. The title of this discussion was HIV and Me. What role do I play in understanding, preventing, managing, navigating HIV in society? I'm sure you'll appreciate that this is a question everyone has to answer for themselves. I'm not able to give you all of the solutions to the challenges that we've posed today, but I hope that I've been able to give you some ideas as to how you can frame your internal discussion and dialogue, and indeed your external conversations around HIV, in a way that looks comprehensively and holistically, not just at how the virus works and what it does, but also the people who are infected or affected by it. Some of the questions that I would like to pose to you today. Do I know my status? Am I HIV positive or am I HIV negative? And if I do not know my status, or if I'm apprehensive about determining my status, what are the considerations that are stopping me from knowing? And to take that discussion further, if I feel anxiety about knowing my status, what kind of anxiety would be felt by people in positions different to mine, members of marginalized groups or the key populations that we've discussed? How can I relate and empathize with the challenges that they're facing? Am I at risk for HIV? And as we've discussed, HIV can affect or infect anyone in society. Listening to this discussion, if you are a healthcare provider or a future healthcare provider, as per definition of being in your chosen vocation, you are at risk. What are you doing to manage that risk? And what is someone who doesn't have the same kind of expertise and education and social privilege as you doing to manage their risk? How do we intervene in a way that empowers them? Does HIV affect me, be it personally or professionally? And I hope you'll recognize at this point in time that we are all affected in one or another capacity by HIV, and that the way it affects us might shift over time. Again, we pay some understanding to the way that HIV affects people in situations different from our own, using our own feelings and our own experiences to tap into some compassion and understanding for those whose narratives are different from ours. In terms of the systemic injustice and the barriers that we've spent so much time unpacking in this discussion, are we as healthcare providers perpetuating the barriers, or are we doing what we can to dismantle them? If a patient sits in front of us and we tell them, you need to always use a condom, are we really serving the greater cause by telling them information that undoubtedly most people in this day and age already know? Or do we need to broaden the conversation with them, engage them, interact with them, find out what it is that might be preventing them from acting on this information? Are we combating the stigma? Do we see ourselves just as healthcare providers, or do we see ourselves as having a responsibility to our fellow human beings to act as an activist in this space, using our skills, our background, our education, and our capabilities in order to tackle the injustice that permeates this world? Do I have a role just as a clinician to give instructions and order medication and diagnostic tests, or do I have a commitment and a responsibility also as a human being to do everything that I can to restore the agency and autonomy to groups who have lost it, to meet them on their level, to have conversations with them, and to really try and understand what they're going through so that we can make a difference in empowering, uplifting them, allowing them to make their own decisions about their lives and their healthcare in order to stop the spread of this infection. In having this discussion, if I don't consider the systems that these inequities and injustices are built upon and the effects that it has on differing groups, I will never be able to pull HIV apart from the rest of this complex picture and tackle it on its own. My approach, and I hope your approach, has to be one that is holistic and comprehensive, paying respect to all of these complicated factors and the role that they play. If you need more resources, and I think that we all do, I'd encourage you to visit avert.org, where you'll find a growing body of evidence-based research, as well as resources for patients and for healthcare providers that pays respect and understanding to the unique situations and nuanced experience that we've touched on today. Thank you for participating. Thank you for reflecting. Thank you for tapping into your compassion and your empathy in having this discussion about HIV and me.